50. I think we'll start with some brief comments, introductions, and then in about a minute, we'll get started with our first speaker, who I see is here. Wonderful, wonderful. Thank you all for joining us today. This is the second installment, as stated of the Resident Research Symposium that we do every year to showcase and highlight the great work that our residents are doing on the research side. For those who may not know me, I'm Christy McDonald. I'm a faculty member in this department. I am Vice Chair of Research. And so as many of you are training them on the surgical side, I'm helping to teach them to be the research side of the academic neurosurgeon. So the boss has myself and my colleague Mike Levitt join to conduct the symposium this time of the year. We have a great lineup this morning, 9 speakers today. We're going to actually start off, since she's here, and we're basically at time, with Dr. Zirun Zhao, who will be telling us about some work she's doing with Dr. Goldstein in pediatric patients. And we'll let her cue up her slides that she'll be discussing the role of CSF liquid biopsy in the early diagnosis of pediatric CNS tumors using long read sequencing. So some unique advancements also in technology that are coming to fruition for these very important patient populations. So Zirun, would you like to take it away?
Thank you, Dr. McDonald. Good morning, everyone. My name is Zirun. I'm one of the PGY4 residents in the department. Today, I wanted to share my research year project, very excited about it with all of you, which is titled The Role of CSF Liquid Biopsy in the Early Diagnosis of Pediatric CNS Tumors. Wanted to thank the support of the principal investigators, Dr. Goldstein of our department, Dr. Crotty, who's of the Hem-Onc department at Children's, and also Dr. Miller, who is part of the pathology department and who are instrumental in this work. First, I wanted to provide some background of the study. CNS tumors are the most common solid tumors and the leading cause of cancer death in children. And molecular alterations and analyses of these tumor samples have really revolutionized the way we think about these tumors and the way we treat about these tumors in the last couple of decades, really. BRAF MEK mutations and the subtypes of medulloblastoma is essentially how we define these tumors these days. Now, the pathology samples are obtained traditionally through tissue biopsy, which has non-trivial risk. Surgery first has risk of hemorrhage and neurological deficits, and some of the midline tumors may not be safe for biopsy, particularly for optic pathway gliomas. And single sampling may miss the tumor heterogeneity, which may not represent the whole picture of the tumor. In part of the follow-up of these tumors, the imaging surveillance also has some gaps that needs to be filled. Radiological follow-ups often lack sensitivity to detect early disease recurrence, and sometimes it is quite difficult to differentiate radiation necrosis from tumor progression, as demonstrated by many debates at the tumor boards. Now, one of the emerging solutions to address some of the caveats that I mentioned is CSF liquid biopsy. It is an emerging technology that analyzes the cell-free DNA in cerebrospinal fluid. It is less invasive by the nature of the sample, which is obtained through ventriculostomy or LP or intraoperatively. It is thought to capture tumor heterogeneity across a whole lesion, and there is pretty convincing evidence that I will show in the next slide across multiple pediatric CNS tumor that this is efficacious and able to have the sensitivity to detect the molecular alterations that we care about. On this slide, it's a little busy with some of the evidence, mainly in the last 5 years, where people have begun to look at liquid biopsy in all CNS tumors, but also in pediatric tumors in particular. That includes midline glioma, medulloblastoma, and most of the common ones that we see. This diagram on the left really represents kind of the whole spectrum of the application of CNS liquid biopsy. The first piece is the diagnosis piece, where it has a minimally invasive way of obtaining the samples and really getting a therapeutic target and the genetic mutations. It also can quantify the genomic risk with the whole genome analysis. And what I think is really cool is also with the follow-up piece, in taking care of these children, because this is a unique way of potentially being able to identify the genomic evolution of these tumors as they finish treatment and is in the surveillance phase. And there is also a potential to really detect molecular residual disease and have that really early detection before the imaging evidence of tumor occurrence. I wanted to highlight a pilot study at Seattle Children's, which is really the basis of my project. It is led by Dr. Leary and Dr. Crotty's group, and where they looked at 17 CSF samples that were collected in 15 patients with CNS tumors and analyzed the cell-free DNA in the cerebrospinal fluid in these kids. The sensitivity is 53%. They were able to detect 9 out of 17 of these samples, making the diagnosis with cell-free DNA. And all of the somatic mutations and copy number variations were detected in the tumor tissue, and there is a 100% concordance rate with that diagnosis compared to the gold standard of tissue biopsy. I wanted to highlight 2 details in this study. All of the CSF were collected via ventriculostomy, LP, or intraoperatively. For EVD and LP, the samples were obtained after surgery, 2 days, and in the case for LP, probably 30 days after surgery. The median volume required is quite low, which makes it safe for most children. And the analysis in this study was using next-generation sequencing with the UW Oncoplex, which has really quite an amazing sensitivity and ability to detect most common genetic mutations in all of the 5 tumor types that are listed here. I also wanted to briefly introduce long-read sequencing, as that will be the method for my project, which is a new technology that reads longer sequences of base pairs compared to next-generation sequencing and UW Oncoplex, which is our current standard. And the main advantage is that it has a shorter turnover time, mostly 30 to 40 minutes in literature, and getting a diagnosis in less than 24 hours. And there's some evidence in using this technology to aid intra-op decision-making and really make a rapid diagnosis. So across a whole spectrum of the application of CSF liquid biopsy, I wanted to focus on the early diagnosis piece in this particular project. And our central hypothesis is long-read sequencing of CSF cell-free DNA is able to help us with early diagnosis and faster implementation of targeted therapies. With this particular project, I have 3 aims, and the first 2 aims are really aimed for 1, the feasibility of early diagnosis, and 2, improving the rapid turnaround time. For the first aim, we will try to demonstrate the feasibility of getting the liquid biopsy samples before any tumor manipulation, which is really kind of making the groundwork for a future where surgery biopsies may not be needed for some of these midline lesions. We will try to obtain ventriculostomy, LP, or intraoperative samples and establish a protocol for optimizing the collection, storage, and time to processing so that we can optimize the yield. And the second aim will be working with Dr. Miller's lab to improve the turnaround time. Currently is 2 to 4 weeks with UW Oncoplex, and our target for LRS would be less than 24 hours, which really get that rapid diagnosis even in between the placement of EVD for kids who present with hydro to the time of their surgery. And our third aim will be to optimize the location of CSF sampling based on different tumor types. This is the study that I was highlighting previously, and the teal boxes here represent the CSF from LP, which a lot of them unfortunately do not have the yield or sensitivity to detect cell-free DNA. And really a preliminary thought on this is the LP is just farther away from these brain tumors, which makes them having a less or fewer cell-free DNA in that location. But we would like to really parse the tumor types and the collection of cell-free DNA CSF and see which part would be a higher diagnosis. Quick summary, we would like to establish an early diagnosis protocol and really implement it in the clinical practice. decrease the turnover time with this new technology, and 3, optimize the sampling site, which is the main scope of our project. Really, I think this is an exciting way of just incorporating into a new and faster way for these children who present with a new brain tumor diagnosis, which is some of them not amenable for surgery resection, and really get them a quick diagnosis within a couple of days as opposed to several weeks, and get them to treatment or clinical trials with their molecular alterations, and really have a very personalized way of following up for these tumors. Finally, I wanted to acknowledge my mentors, Dr. Goldstein, Dr. Crotty, and Dr. Miller for this project. And I also want to thank Dr. Lee and Dr. Ellenbogen for their continued mentorship and departmental support. I will take any questions.
All right, very nice work, Zirun. I see Dr. Ravenpay has his hand up. We have a time for a quick question.
Okay, thank you. So Zirun, my question is probably a reflection of my ignorance of the fundamentals of how the technique for this project. How do you come up with your target? Because since some of these or many of these tumors are heterogeneous, and does that tumor heterogeneity also explains the kind of what seemed to be a 53% or 50% specificity? Is it because you have some targets that sometimes work and then other targets that change with time, or you didn't think about? But that is a reflection of maybe I don't understand what your targets are.
Yeah, that's a great question. UW Oncoplex, which is currently the way they analyze these cell-free DNAs, have their set of genes that they test for. And then for LRS, we would probably target the same set of genes. And I think your thought is a great one, because there might be some mutations out there that we're just simply not detecting with our assays. But I think currently at this stage where we're working on, we're just targeting to hit the most highly frequent mutations in particular tumors that may have meaningful therapeutic targets. So that's a great question, and I think there's a lot to be explored, but right now we're just targeting the most common ones.
Thank you.
And I would just say to you, Zirun, you might want to, explore the mechanism of collection, because I'm with you. I think there's going to be some of that sensitivity. I would actually have been curious to see how it lines up with the mechanism. Was it the LP? Was it the actual like pre-op, post-op that were the ones that actually worked and did not work? Because there may have been some reasons that drove the sensitivity down. But again, advancing technology, right? Like you're at the forefront of this, which is very exciting. Well, thank you so much for that great presentation. We'll move on to our next speaker. Our next speaker is Dr. Kevin Vanent. We are going to move into functional realms these days, and he's going to tell us about some neurostimulation work that he's been doing with the institutional case series looking at Pulvinar Nucleus for medication-refractory epilepsy. So Kevin, would you like to share your screen?
All right. Is everyone able to see my screen okay?
Yep, coming in
Perfect.
and in presenter mode. So
right.
Good to go.
All right. Thank you for the introduction, Dr. McDonald. Sorry, you say the presenter view or my slides?
The correct view for us as the audience, yes.
Oh, perfect.
Oh, sorry, I said presenter. Don't listen to me. What do I know about technology? We don't see the second preview slide, just the one you're on.
All right, perfect. All right.
Apologies.
Yeah, thanks for that introduction, Dr. McDonald. Excited to talk about my research. This is a project that I'm working with Dr. Granite and also Dr. Costello, who's been sort of my mentor for this as well. But my project is titled Responsive Neurostimulation of the Pulvinar Nucleus for Medication-refractory Epilepsy. And this is an institutional case series looking at the cases that we've done here at the University of Washington. So I have no disclosures. Just briefly, as a background, epilepsy affects over 50 million individuals worldwide, and approximately 30 to 40% will develop medication or drug-resistant epilepsy. For adults with focal seizures, resective or ablative epilepsy surgery can provide seizure freedom or significant reduction in select patients. However, many patients with MRE are not surgical candidates due to multifocal or non-resectable seizure onset zones, lack of a discrete lesion, or unacceptable risk to eloquent cortex. In this population, neuromodulation has emerged as an important therapeutic option. RNS has become a widely utilized method for treatment of MRE in both focal onset and generalized epilepsy. So DBS and RNS targeting thalamic nuclei have demonstrated promising efficacy and safety for patients with refractory focal and generalized seizures. DBS of the anterior thalamus, anterior nucleus of the thalamus was validated in the Santee trial where 50% seizure reduction was achieved in 68% of adult patients at 5 years. And similarly, the central median nucleus has been targeted by both DBS and RNS with various studies showing greater than 50% responder rates. These findings highlight the thalamus as a critical hub for seizure propagation and attractive target for neuromodulation strategies. While most studies have focused on the anterior and central median nucleus, recent attention has turned towards the pulvinar nucleus as a potential target for posterior quadrant epilepsies. The pulvinar's widespread reciprocal connections with the parietal, temporal, and occipital cortexes suggest that it may play a key role in seizure propagation from the posterior networks, and its involvement in posterior quadrant epilepsies makes it a compelling neuromodulation target. But unfortunately, significant gaps remain given the limited cases. So here we present our early institution experience with RNS targeting the pulvinar nucleus for adults with MRE. So we performed a chart review of all patients with MRE who underwent pulvinar RNS placement at the University of Washington. Patients were selected for pulvinar thalamic neuromodulation with RNS via a multidisciplinary conference that included epileptologists, neurosurgeons, neuroradiologists, neuropsychs, and then social work as well. Device selection with RNS was made based on patient and family preferences, access to postoperative programming, and also specific or target-specific benefits based on the etiology of epilepsy. The leads were placed with the ROSA robot, and target selection within the pulvinar nucleus would depend on thalamic connectivity and seizure onset zone. There are small adjustments to the trajectory based on the individual's ventricular anatomy and also the region of the pulvinar nucleus that was felt to best target their connectivity pattern involved in epilepsy. And then at follow-up, we sort of assess the seizure frequency and the functional outcomes. And outcomes we examine include the overall satisfaction by the patient, mood, cognition, work status, and also driving status as well. So we reviewed a total of 7 patients who underwent pulvinar RNS at the University of Washington, and this was between 2022 and 2025. The mean age was 33 with a median of 30, and 2 of the 7 patients were female. Of the 7 patients, about 5 patients had at least 1 year follow-up data. Post-RNS implantation, 6 out of 7 patients experienced a reduction in seizure frequency, with 1 patient having an angle classification of 1, which is pretty much seizure-free. It's important to note that the 1 patient who did not have any improvements, this is the patient who had less than 1 year follow-up there in the early programming stages, and they actually transferred their care to an outside hospital. And so, unfortunately, we don't have any subsequent follow-up data for them. And just for the sake of time, I just want to highlight 2 cases where patients had significant improvements after pulvinar RNS. This is the first case. It's a 42-year-old man with history of left vertebral artery dissection, fatty liver disease, and obstructive sleep apnea. So nothing remarkable. But he had seizure onset at the age of 16 when he lost consciousness while wrestling with his brother and awoke in the hospital. He was initially on phenytoin at that time, and over the course of his disease, was initially on several anti-epileptic medications without good adequate control. Over the course of his disease, he developed 3 seizure types listed here. He had focal aware seizures that occurred approximately 3 times per week, focal impaired awareness seizures that occurred about 1 to 2 times per week, and then also some rare generalized tonic-clonic seizures as well. Pre-surgical evaluation included MRI, which showed concern for mesiotemporal sclerosis, and then also PET as well. He had 10 days of intracranial monitoring that demonstrated widespread interictal discharges from the temporal neocortex and some less frequent activity from the subtemporal and anterolateral temporal strips. He had 3 seizures captured, but there was no clear onset, and they had rapid bilateral spread. Prior to his RNS placement, he had an AD regimen that included zonisamide, carbamazepine, lacosamide, and he also had clonazepam pyridine as well. So this patient ultimately underwent RNS placement with leads targeting the left occipital cortex and then the left pulvinar nucleus. At 3 months postoperatively, he reported marked clinical improvement with only 2 seizures since surgery. At this time, detection parameters were adjusted, but stimulation settings were unchanged. At 6 months postoperatively, he reported one clinical seizure, but overall reported improved mood. And by 9 months postoperatively, he reported complete seizure freedom, which persisted as 2-year follow-up. During this time, he also began driving as well. At 3 years postoperatively, he was doing well. He had only reported 2 to 3 brief focal aware attacks that all occurred during times of significant stress. However, he remained significantly pleased with his overall status and continued to work full time. For this second patient, this is a 51-year-old woman who underwent MRE after resection of a tentorial meningioma. She had seizures shortly after her resection, and that's actually how she presented to the hospital. She developed 4 distinct seizure types. She had focal impaired seizures that occurred about once a week and lasted several minutes. She had focal aware seizures that sort of occurred multiple times per week and clustered throughout the day. And then she had some visual seizures and then some rare general tonic-like seizures as well. She, throughout her epilepsy course, she tried 8 anti-seizure medications without adequate control, and then preoperatively serial EEGs showed that she had focal slowing in the right occipital pole and parietal regions with interictal discharges that spread rapidly to the occipital contacts. She also had 3 seizures captured, and these seizures either started in the right parietal context and spread to the occipital region or vice versa. This patient ultimately underwent RNS placement with the right pulvinar depth electrode and a right parietal occipital strip. Unfortunately, at 4 months, she developed a wound infection at the generous site and underwent a washout. There was no involvement in the cranial components, and so she completed her antibiotic course and had her generator reimplanted shortly after. She had no further complications related to this. At 3 months post-generator replacement, she reported reduced seizure frequency and severity of her most disabling seizures. Though she reported that she still had some visual auras, and at 1 to 3 years, she reported similar circumstances where she continued reduction. So in summary, we reported the clinical outcomes of 7 patients, 2 highlighted here, who underwent Pulvinar RNS at the University of Washington. We saw beneficial seizure reduction in patients who have been implanted for at least 1 year, with patients having more recent implants showing promising improvements with initial programming. These patients should be followed closely, and long-term data should be collected. Overall, early outcomes suggest that Pulvinar RNS is a safe, viable option for MRE, specifically affecting the posterior quadrant. And just for acknowledgements, I'd like to just thank everyone who contributed to the project, and specifically, I want to give a big thank you to Dr. Costello for sort of guiding me through the project and sort of educating me on, or sort of exploring the functional world.
All right, great talk, Kevin. Any questions from the audience out there in the internet realm? We have time for a quick question. I'm just curious to ask you. So, you presented the summary data, but then the 2 cases that actually you presented were kind of on the older side. Getting into some of the subdivisions that typically happen with kind of finding that ideal patient profile. From these early cases, do you all have any inklings of kind of, what that would look like for this particular treatment? Is it better if they've actually, been, had seizures for a period of time or longer or a little bit older or have oddly enough even different comorbidities? Do you kind of have any insight about kind of the ideal patient for this type of treatment?
Yeah, I'll say that it's hard to say. All the patients that we included or reviewed had very different comorbidities and sort of different seizure patterns. The patients I highlighted were the 2 oldest patients, and then the reason why I chose them was because they had the longest follow-up data. But more recent patients, they also had promising outcomes as well, except for that 1 patient who I mentioned that sort of transitioned their care to another facility.
Excellent. And maybe that's the answer, is that there's, some universal applicability. So, even better for options for very challenging patients to seek some benefit. Well, fantastic work. Thank you so much. I think in the interest of time, we'll move on to our next speaker. We're going to go back to talk about tumors, and we're going to go to Dr. Meredith Costello, and she's going to tell us about the work she's been doing in same-day discharge after craniotomy for brain tumor resection, and a prognostic scoring system that they've been looking at. So I'll turn it over to Meredith.
Thank you, Dr. McDonald. Can you see my slides?
Yes, and you're in the correct mode because I don't know technology and I'm using the wrong terms. So it's what it should be for what we see. Yes, it's perfect.
Thank you. This is actually a project that I worked on in medical school with some of my mentors down in Miami, Dr. Komatar and Dr. Ivan. I chose to present it today. Neuro-oncology has always been something that I've enjoyed even in medical school, and it's one of my main interests now. But it's a same-day discharge after craniotomy for brain tumor resection, and it's an expansion on a prior pilot study that was done in Miami prior to my arrival in medical school there, and then development of a prognostic scoring system. For a little background, so enhanced recovery after surgery protocols aim to lower risk of infection, exposure to medical error, psychological burden for patients, and then also overall cost for both patient and the institution. And like I had mentioned, there was a previous pilot study that was done by the group from August of 2020 to 21. They had a successful same-day discharge rate of 86% with no repeat neurosurgical interventions or complications in the 30-day post-op period. This is a little bit of the overview of the flow and patient selection. So out of the 750 procedures that were performed, 37 were ultimately deemed eligible. And then 32 had successful discharge home, with 5 that were admitted for further observation. And for the workflow for the same-day discharge cases there, it essentially starts with plans for booking the case. The APPs, residents, MRI and CT staff, administration, and both the physical therapy and occupational therapy teams are all notified. And patients are typically admitted the evening before surgery, both to get a fiducial MRI and then also for pre-op clearance, mostly for monitoring blood pressure, making sure they're all teed up for the OR and anticipating any barriers or problems that may arise post-operatively that would impair their same-day discharge home. It really only works with the first start cases at 7:30 a.m. They are taken to PACU post-operatively, examined by a resident, and then taken to MRI on their way up to the neuro ICU. Once they're in the neuro ICU, they're seen by both PT and OT, which would clear the patient, re-examined by a resident, images reviewed by the attending, and then discharged home by 5 p.m. With a minimum observation time of 6 hours. So in the pilot study, they saw no very early hospital readmissions, which they categorize as 1 to 3 days after surgery, and also 4 early readmissions 4 to 30 days after surgery. 3 of them are very much unrelated. The one patient that had seizures with known epilepsy was deemed unrelated by the treatment team. Unfortunately, I don't have further details in terms of what that looked like and the type of seizures they're experiencing or where their lesion was. So in the present study, we expanded on the pilot study and then evaluated the feasibility of same-day discharge on a larger scale, and then also came up with a prognostic scoring system to help aid the other surgeons at other institutions in guiding their patient selection. It was performed from August 2021 to August of 2022, and data was prospectively collected for the selected patients. And then for patients who qualified for same-day discharge, either were not included at the attending's discretion or chose to not undergo same-day discharge, we retrospectively reviewed the data. D groups are analyzed and a scoring system was created. So continuing on, for the inclusion and exclusion criteria, it remained the same from the pilot study with the exception of eliminating BMIs, sorry, this should say greater than 35, which was other institutions have also used, which we lifted on this study. But mostly it's young, healthy patients with a good functional status, tumors less than 4 centimeters, estimated blood loss of less than 300, and a predicted max surgical time of less than 3 hours. We did not include intraventricular infratentorial tumors, pituitary skull-based tumors, need for CSF diversion postoperatively, anyone with limited home support, and surgeries that start after 8:30 a.m. So for the results, 31 patients were ultimately selected, with 59 patients who qualified as outlined by our criteria, but were either not included based on the attending's discretion or declined themselves. We found that negative predictors of being chosen for same-day discharge by the attending were prior treatment, including any sort of craniotomy, radiotherapy, chemotherapy, any motor deficit as a part of their constellation of presenting symptoms, left-sided lesions, and then positive predictors were any extraaxial lesions and tumors less than or equal to 11.75 centimeters cubed for volume. So for the results of this study, there was 3 patients that were initially planned to discharge same day who ended up staying. There was one who was transiently combative and disoriented, and we admitted overnight for observations. There's a patient with transient diffuse weakness that was also held overnight for observation, and then someone who was slow to emerge from anesthesia, but they were exclusively Hebrew speaking, and it was hard to get an in-person translator there. So based off of this, we combined our 2 groups and created a scoring system using the significant pre-op variables from the multivariate analysis, and then weighted the point values based on the odds ratios from the final binary logistic regression model that I've included in table 5 here. And so the left-sided lesion and up here in table 6, so there's both the inclusion and exclusion criteria that I was talking about, and then also in step 2, so points awarded -1 for both left-sided lesion and previous treatment, and then +1 for extraaxial pathology and tumor volume less than or equal to 11.75 centimeters cubed. With a total score ranging from -2 to 2, with the negative side being, probably would not recommend discharging same day, and then more positive scores being better predicted outcomes, with 0 being equivocal. And then we applied the system to the entire patient cohort, including the patients from both the pilot study and the current study. And I've included the model performance on the left, and then the ROC curve with an area under the curve of 0.83, indicating that our system was performing well. So in conclusion, and kind of final thoughts, proper patient selection is crucial. Less than 10% of our patients qualified for same-day discharge using our predetermined criteria. And I think the big takeaway is, yes, it can reduce hospital burden, less patients in the ICU, reduce costs for patients and the institution, but when using the appropriate patient population, it is safe. In our group, 90% of the patients successfully underwent same-day discharge, and in the literature, this can range from anywhere from 82 to 94%. And we saw no significant differences in readmission complications or ED visits in our selected patients that discharged home the same day. And I included the PubMed ID of both this study that I'm talking about, and then also the pilot study if anyone is interested in reading more about those. But I'm happy to take any questions.
All right. Thank you so much. I see Dr. Williams has his hand up, so we'll go over to Mike.
Thanks very much. It's an interesting study. I used to take care of patients in the neuro ICU many years ago. Were patients consented to participate in this trial?
Yes, they were. It was a IRB.
So what do you know about the patients who didn't consent? Are they different from those who did, and does that influence the outcomes of your study?
That's a great question. I do not have the information in front of me of the patients who didn't consent, but that's a great point.
Yeah, I think you'll really need to understand if that population is different from this selected and then self-selected population. But a very, very interesting study. Thank you.
Thank you.
And a really important point that Dr. Williams raises that we face and now have to think about more these days, which is the who says yes to research versus how representative are they of any of our patient populations that we are trying to better understand. Great work, Meredith. Thank you so much. I think in the interest of time, we're going to transition on. Our next speaker is Dr. Fatima El-Ghazali, and she'll be telling us about a retrospective study work that she's been doing in symptomatic patients with titanium plate-related problems over the last couple decades. So I'll turn it over to Fatima. And slides look great. You should be good to go. Although, Fatima, if you're talking, we can't hear you. You might be on mute.
Can you hear me now?
There we go. All right.
Thank you, Dr. McDonald. So today I'll be talking about complications of titanium implant use in cranioplasties, specifically at a retrospective analysis that we're doing under the guidance of Dr. Shaker. So, sorry, where did my screen go? There we go. So titanium, the use of like plate-based reconstruction systems, specifically titanium implants, have been widely regarded as a standard approach for both emergent and elective cranial surgeries, as they provide immediate stabilization of the cranial flap, restore skull integrity, and allow for rapid functional and cosmetic recovery. Despite these advantages, cranioplasties are associated with a notable risk of postoperative and long-term complications, such as infection, hematoma formation, implant failure, hydrocephalus, amongst others. There have been various studies that looked at some of the factors that affect this and certain patient demographics and comorbidities, in addition to surgical approaches, have been found to possibly correlate with titanium plate complications. So just a little bit of background. There's been a varied range of rates of complications when it comes to titanium implants. Some of the literature states as low as 17%, others or 15%, others as high as 35%. And the true incidence of these related complications could even be underreported, just given the fact that we lose a lot of patients to long-term follow-up, as we're seeing from the study that we're doing. There's also been various risk factors that have been found associated with these complications, including the size of the cranial defect, the traumatic nature of a certain patient or certain etiologies for cranial fixations, elderly age, smoking history, radiation history. And then there have been various approaches that have been implicated, such as bifrontal approaches versus posterior lateral. There's also been varying data on the complication rates, comparing titanium implants to other implants, such as PEEK or bone cement. So certain studies say that there has been higher infection rates, but comparable complication rates, versus other studies are saying there are higher complication rates and lower retention rates. So our study overview, we are doing a retrospective analysis to evaluate the postoperative cranial wound complications following the use of titanium implants in cranial fixation by a single neurosurgeon, Dr. Shaker, at this institution over the last 20 years. So we did an evaluation of all of the surgical log database of Dr. Shaker's and looked at every patient who has undergone a surgical intervention between the years of 2005 and 2025. That ended up being a total of about 3,400 patients. From there, we looked for patients who had required to go back to the operating room for wound revisions. And specifically, all these patients actually ended up having titanium implants, just given the fact that that's what we had been using in the past. It ended up being a total of 41 patients that we had chart reviewed, looking at their patient demographics, their comorbidities, and their surgical details. So some of the patient factors that we looked at were age, sex, comorbidities such as cardiovascular disease, hypertension, diabetes, obesity, and then we also looked at their social history, specifically smoking history, alcohol use, and recreational drug use. We also looked at two really specific medications, steroids or immunosuppressants, and then anticoagulation use. In terms of the surgical details, we looked at the initial surgery date and then the time they represented for wound complications, the details of the wound complications, and the details of the wound revision, what they ended up getting in the operating room. We also categorized all the surgical approaches into these 5 broad categories: bifrontal approach, frontotemporal, which made up most of the interventions, and then petrosals, retrosig, and far lateral were combined, and then suboccipital. We also assessed whether or not they've had any radiation therapy or if they required any shunting. So here we have some of the results. So the total of 41 patients were between the age of, or had a mean age of 46. The cohort included about 22% male and 78% female. The mean time to postoperative cranial wound complication was around 331 days, about a year, but the range was pretty wide, starting from 1 week post-op to several years out. And then of note, all the initial craniotomy closures were actually performed with sutures for closure. So there was no comparison between that and staple use. In terms of the initial surgical indication, the highest ended up being tumors and aneurysms, which is probably just a reflection of the surgeon's practice rather than an association with the titanium plate use. In terms of the comorbidities, we have it here laid out. We saw that their highest comorbidities associated with titanium plate implant complications were hypertension and obesity, up in the 30s percentile, followed closely by smoking, blood thinner use, and alcohol use in the 20 percentile. And then less common was cardiovascular disease, steroid use, diabetes, radiation therapy, and recreational drug use. So we kind of talked about pathology, but in terms of the surgical approach, the most common was the frontotemporal craniotomy, followed closely by the retrosigmoid far lateral approach. Bifrontal, petrosal, and suboccipital were a lot less common. So in terms of the next step, right now we're analyzing the details of the complications, looking at early versus late complications. Usually the early complications have been hematomas, infections, hardware failure, or breakage. And then the late ones are usually hardware extrusion, loosening, skin, thinning of the skin over the hardware, or bone resorption. We're also doing comparative analysis, looking at the different cranial fixation methods, specifically autologous versus synthetic, whether or not absorbable versus titanium plates were used, and then the use of bone cements. We are also, I think one of the next steps would be expanding the study to look at multiple surgeons within the institution or even multiple institutions to get a wider range of data.
All right. Well, and I see Dr. Robert Pay has his hand up. So we'll start there and then we'll go to Dr. Chestnut. Ali, do you want to start?
Thank you, Fatima. A quick question. I didn't see that you specifically stratified based on patients who get bypass, because obviously when the SDA is involved in providing blood to another part of the body, it can affect wound healing. And I wonder whether in your graph possibly you had anticoagulants being as one of the two after hypertension risk factors, which I wonder whether is an indirect correlate of patients who had bypass being part of the question of wound failure.
Yeah, no, that's a good point. We didn't stratify based on bypass, but I think that brings up a good point and something we can definitely delve into further.
All right. And I see Dr. Chestnut has his hand up as well. So, and we've got time. So if he wants to hop in, Randy, you're going to take the floor.
Yes, I would just like to stress that there are a plate is not a plate is not a plate. There are a lot of mechanical considerations in terms of orientation, choice of plates, number of holes, contouring of plates, length and type of screws, whether or not they're freehand placed or drilled, and if they're drilled, whether or not there's irrigation used to cool. For instance, if you don't irrigate you cause bone necrosis, increasing the risk of infection and pullout. And there's a fair amount of that data in the plastics and oto literature. I would just like to stress that in your prospective work that you try to characterize some of these variables so that the results are generalizable to the proper group.
Yeah, thank you, Dr. Chestnut.
All right. Excellent point raised. Always more complicated than when we start. And you have to start someplace, but I agree, can expand out. And I do see we have the good Dr. Derrick Lewis with us. Fantastic. Okay, so we will stay on the originally planned schedule and we'll go to Derrick, who's going to be telling us about the clinical utility of hourly neuro exams after acute non-traumatic brain injury. Do they help? Do they matter? Would you like to share screen, Dr. Lewis, and take it away?
Yes, I would. Thank you.
Okay.
Introduction. Looks like my slides have advanced a little bit faster than I expected. Hold on just a moment. All right. Doesn't seem to be going back. That's okay. We'll just start on this slide here. So yes, good morning, everyone. As mentioned, I'll be discussing the clinical utility of hourly neurochecks and specifically vascular injury patients. So large vessel occlusion, spontaneous intracerebral hemorrhage, aneurysmal subarach. This is actually motivated by something we frequently encounter on call, right? Which was, nursing's asking, ICU staff is asking, patients are asking, the parents are asking, since I'm now at Children's, can we space out neurochecks? And we have this tension that always exists where we want to expeditiously discover if there's any neural decline that could potentially be managed medically or surgically so that we can improve outcome versus the complications that come with QI neurochecks for days on end, which are delirium, fluctuating exam, lots of CT scans that may reveal nothing, and in general a lot of harms that we may perhaps underestimate as neurosurgeons. And my first look into looking at this background as I was on call as a junior resident, always seeing patients that were fluctuating and being frustrated by the fact that their CT scan showed nothing, I started looking into different groups. Northwestern is a group that has been looking into the temporal profile of neurochecks as regards to cerebral hemorrhage. And they had a graph that really caught my eye, which was showing this decline, the risk of decline, according to the time course of their care. And really, the first 3 hours, they found that that's where most of the GCS declines happened. And then you start to decrease precipitously until around 10 to 12 hours, where your risk of decline is about the same as if a week later. And so that then begs the question, why would we do Q&R neurochecks for this particular pathology beyond the first 24 hours, the first 12 to 24 hours? But I wanted to investigate that in other types of groups. So I included LVO and aneurysmal subarach, and to explore not only the temporal profile, but also kind of the yield of clinical exams. So my 3 aims were yield, how often do neurochecks lead to intervention? Specifically, I was thinking about surgically intervention. What's the natural history? Is there a certain period where we could stop doing current neurochecks and then pick it back up several days later? And then thinking about the relationship between neurochecks and delirium, which is my hypothesis that these current neurochecks are leading to delirium without necessarily giving us much. So as far as inclusion criteria, this is something that I started at University of Florida and just kind of continued throughout the year. 1,300 strokes we obtained from the stroke database. 191 patients ultimately met our inclusion criteria, which were adults aged 18 to 89 in the ICU with any of these diagnoses and had an ICU stay greater than 24 hours. Had a pretty even split between LVO, subcutaneous ICH, and aneurysmal subarach. So as far as basically table 1, baseline characteristics, they were pretty similar, the groups, and notably aneurysmal subarach tend to trend towards younger patients, somewhat healthier as far as comorbidities compared to our strokes and spontaneous ICH, which makes some sense. You'll notice that down here, it's duration of hourly neuro examinations, 304 as our average compared to 92 in LVO and 156 in spontaneous intracerebral hemorrhage, and an ICU stay of 14 days plus or minus 10, which makes some sense given the vasospasm window and how long we monitor these patients. Not unexpected, delirium at a rate of 58% in aneurysmal subarach, which is higher than the LVO of 33% and the spontaneous ACH of 51%. So by the numbers, as I mentioned, 191 patients, 35,000 neurochecks. I mentioned that because we read every single one. So every single time in nursing you mentioned a GCS, we were looking for, is there a decline greater than 2 of the GCS, or is there a decline of 1 from the MODA score, or is there a focal neuro deficit? And so, at some point in the time course, 3/4 of patients ultimately had a neural decline. Very common. There were 600 neural declines, though. So only 1.27% of those 35,000 had a neural decline. And so looking at the total cohort, doesn't include all the data that we acquired just for the sake of time, but just you see in panel A, right? These are all the neural checks. You see the detected decline is this tiny sliver, this orange to 2%, and then that is expanded out in panel B to what happened when we interpreted that decline. And so the vast majority, 3/4, no consequences. Didn't even get a scan, just chalked it up to probably delirium. It wasn't significant enough to where they thought they were concerned. About 12% end up getting a head scan, either a CT or MR, and 6% end up getting a neurosurgical procedure. So we see of these 2% of these neurochecks with decline, 6% got a procedure. Oftentimes there was EEG was around 6% as well. Increased exam frequency was pretty similar to 8%. On panel C here, you see some of that, that temporal profile where declines by and large, and I know that it's a little bit hard to see at the very bottom, but within the first 24 to 40 hours is where you see that very large bar of declines where most of them happened. And then there tends to be this logarithmic decrease. There are secondary peaks, which I think correspond to each group and are interesting to think about. So you have a peak that sits at around 3 days, which you might think about LVO, brain swelling. That's when they can have a decline. And then you also have a peak that's about 6 to 8 days, and that's usually your aneurysmal subaract patients. And so there are time periods where you probably want to have a closer look. But for the most part, there are a lot of patients where you could probably relax neurochecks at a specific time. And then panel D just looks at the interventions, and you see neurosurgical procedures, as I mentioned, or primarily was aneurysmal subaract, where they were getting DSAs, and that was happening at that vasospasm window. And so here I just have looking at delirium versus no delirium. What we see is that, kind of as expected, ICU length of stay, you see the p-values less than 0.001 are increased in those patients with delirium. ICU length of stay is increased, hourly of neurologic examination. Certainly, we have a correlation which isn't unexpected. Is it clear whether one leads to the other? I kind of look at my clinical experience and I see, okay, someone develops delirium. We end up doing more scans. We end up watching them for longer. They stay in the ICU longer until they have a stable exam. And so that clinical experience is kind of borne out in the data, but certainly not something where we can definitively, due to the nature of this study, say that this is what's causing this. All right, so as I mentioned, some of the limitations, retrospective, too small a sample for a large multivariate analysis. I collected a ton of variables trying to understand, could we predict who has delirium and who doesn't? I think that, having a larger group, being prospective, working with, our machine learning colleagues would be helpful in terms of predicting who is going to have a decline for an individual patient. What is their probability of having a decline at a particular post-op day? To expand to surgical patients, or at a particular day from, based on how much urine output, what's their sodium, can we predict aneurysmal subaract? When are they going to have a decline? And can we adjust accordingly to mitigate that risk of delirium versus, the discovering that they have a decline that we could do something about? So that's presentation. I look forward to any questions. This is recently published a couple weeks ago. And so I just wanted to show our work. Thank you.
All right. Thank you so much. And I see Dr. Williams has his hand up again, so we'll
Yeah,
go.
thanks very much. That's a nice study. Two questions about delirium. The first is, what criteria did you use to define it? And the second is, did you look at other factors that contribute to delirium, such as age, drugs administered, whether or not there was dementia pre-existing beforehand, and so forth?
Yes, thank you for the question. Yes, so as far as defining delirium, that is also a weakness because this wasn't an ICU that was using the CAM ICU to determine if someone had delirium. And so oftentimes, this was looking through the progress notes. This was if a clinician was making a diagnosis of delirium, often based on the CRAM criteria, but it wasn't something that was clearly specified. And then also capturing any use of antipsychotic medications that didn't have someone that didn't have a history of psychiatric disorder that didn't have another explanation. And so the use of Haldol, the use of Zyprexa, using amantadine and guanfacine were very often used in the UF for anyone who had delirium. So those are criteria, and understandably, it's the challenge of retrospective data, the fact they didn't have a well-defined tool, and that's something that they're going to work on so they can do prospective analysis. And then as far as the other factors, I did collect a plethora of data, all these different demographics. And we found that across the board, it was really the duration of neurochecks that was the strongest factor, even not considering age or dementia, which is somewhat surprising because there have been other studies that really looked at age and dementia, but for whatever reason, our study was really duration of neurochecks that was the strongest driving factor.
Yeah, and I would encourage you to think about different algorithmic approaches this day and age with all the data you are getting to kind of help whittle down really what is the most important, and also just with the advancements of just so much in monitoring in general. I mean, that's always been the argument is, could a bedside, piece of equipment do just as well, right? The kind of concept to help the system, but also the different systems have different approaches to this, and, trying to come up with something that would be more universally translatable to apply kind of more broadly. Okay, well, thank you, Derrick, so much for the excellent presentation. in the interest of time, we will move on to our next speaker. Our next speaker is Dr. Nick Hug, excuse me. Sorry, Nick. One of those mornings, who will be presenting on the safety of stereotactic radiosurgery in the treatment of cerebellar metastases. So I will turn it over to Nick, who can share his screen.
All right. Thanks for that introduction. My name's Nick. I'm one of the R3s. I'm presenting on a study that I'm working on with Dr. Silbergeld, looking at the safety of doing stereotactic radiosurgery in the posterior fossa. I have no disclosures. So just as a bit of background, brain mets, about 20 to 40% of all cancer patients develop brain mets at some point in their natural history. And about 15 to 20% of all intracranial mets end up in the posterior fossa. Most common primary tumors for brain metastases are lung, melanoma, renal cell, breast, and colorectal. And anyone who's been over at UW has seen this many times on our service. And any of the interns who have been through their gamma knife rotation at this point have seen how we manage this both from a surgical perspective and using stereotactic radiosurgery with the radiation oncology department. Stereotactic radiosurgery has really kind of revolutionized how we manage intracranial metastases from a radiosurgery standpoint. There have been a lot of studies looking at the comparisons between stereotactic radiosurgery and whole brain radiation, with kind of one of the main goals of stereotactic radiosurgery being tumor control and delaying the need for whole brain radiation, given the kind of high morbidity of doing whole brain radiation with decreasing cognition and overall worse quality of life. But and it has a very good proven efficacy for treating intracranial metastases. But one of the outstanding questions for SRS has always been the safety of treating things in the posterior fossa. And that's because there's been a fear of causing basically issues that can be due to treatment effect from radiation. In the posterior fossa is a small compartment, so increased edema or increased mass effect is thought to have a higher risk of causing obstructive hydrocephalus. In addition to that, the proximity to eloquent structures such as the brainstem, cranial nerves, makes it so that those areas are just at higher risk. And while this has been a kind of theoretical fear and has made it so that people are more hesitant to do stereotactic radiosurgery in the posterior fossa, our group here at UW has felt that the risks are kind of overstated and has done a lot of stereotactic radiosurgery in the posterior fossa over the past decade or two. And so the goal of this study was to really look at if finding the actual evidence for whether or not these fears are founded. There are a couple of studies that have looked at this topic in some detail. One in 2017, that was a retrospective single institution studies that ultimately looked at about 155 total Mets, and briefly in their kind of analysis ended up finding that developing hydrocephalus after SRS alone or after resection followed by SRS was pretty low percentage in most of the patients. So in SRS alone, there's only 2 patients who developed any new or worsening hydrocephalus out of 140 patients, so about a 1.4% risk. And then a study that was actually just published a couple of months ago in Journal of Neuro-Oncology, and this year was a 2-institution retrospective study looking at patients treated with SRS to large cerebellar Mets greater than 5 centimeters. And they found that only 3% or 3 of their patients required further surgery, either 2 for resection of the Mets and 1 who needed shunting following stereotactic radiosurgery. So overall, kind of aligning with our belief that this is a safe procedure that is something that can be done safely. So we wanted to look at our data though. So going back to about 2013, we've identified this time about 176 patients with over 300 cerebellar Mets that have been treated with stereotactic radiosurgery. And we're really focused looking at primary endpoints of these post-treatment complications more so than looking at treatment effect and efficacy, which is what a lot of those other studies have looked at in the past. So the primary endpoints we're currently looking at are hydrocephalus, either from symptoms or just on imaging, worsening edema in the posterior fossa causing symptoms, hemorrhage into the tumor or surrounding tissue, and then any patients that needed a surgical intervention, either resection, EVD, or shunt. Currently, limiting the follow-up period to about a year after the last round of stereotactic radiosurgery. And I think some of the patients we've picked up in the preliminary go through kind of highlights why that time window is important, or even narrowing that a little bit more. And so far, this is still kind of in the data collection phase and really rounding out all of the data analysis. But so far, we've identified 7 patients of 176 that experienced one of these complications within a year. On breaking it down a little bit, I think there's really 3 that can be attributed to, or that can be somewhat attributed to stereotactic radiosurgery and treatment effect. 2 that were hemorrhage into those cerebellar tumors. 1 that was just worsening edema in the posterior fossa. And then the other 4 patients, 1 was a patient who just had continued growth of their tumor, was seen on imaging, and ultimately underwent resection. 1 also had a thalamic met that bled and caused IVH requiring shunt. And then 2 patients developed leptomeningeal disease leading to hydrocephalus and requiring shunting, all of which I don't think can be attributed to stereotactic radiosurgery and kind of as a subset of the patient data. But even with including all of these as complications, we're at about 4% complication rate for these patients, which is consistent with published data on stereotactic radiosurgery in supratentorially. So I just wanted to talk about a couple of these cases in a little bit more detail, just the ones that I think can be more attributed to SRS. The first was a 75-year-old with a history of colorectal adenocarcinoma. He initially presented to the service with a hemorrhagic left cerebellar metastasis, underwent a gross total resection, and then got stereotactic radiosurgery. He had repeat SRS a year after initial treatment, given persistent disease, and then 6 months after that was hospitalized with obstructive hydrocephalus due to repeat hemorrhage of that left cerebellar mass. At that time, he underwent a subtotal resection and external ventricular drain, which was ultimately weaned and taken out, and he didn't need a shunt. The next case is a 49-year-old female with a history of papillary thyroid carcinoma. She'd undergone many rounds of intracranial SRS to supratentorial and infratentorial mets. 5 months after her second round of stereotactic radiosurgery to the cerebellum, in addition to many other sites, she developed hydrocephalus. MRI confirmed that she had hemorrhaged into her cerebellar mets, and she ultimately underwent a VP shunt placement. I think about a month later, she had care withdrawn in the setting of just not being compatible with her goals of care and overall progression of her systemic disease, which was quite significant in addition to her intracranial disease. And then finally, this last patient, 71-year-old male with a history of small cell lung carcinoma, who had MRIs demonstrating enlarging intracranial lesions, the smallest of which was a left cerebellar lesion here. He got stereotactic radiosurgery to this in addition to supratentorial lesions. At 2 months, he had some decrease in lesion size, showing a good initial response to the SRS, but then 4 months afterwards developed balance issues and word finding difficulty with an MRI that showed surrounding edema and interval enlargement of the left cerebellar lesion favored to be treatment effect rather than true progression on analysis by the radiation oncology team. He was treated with dexamethasone and did have some improvement, but ultimately transitioned to hospice care, again, more in the setting of his overall clinical picture and not specifically related to this. So next steps, we're still really in the data collection phase of this. I think one of the big things that we're working on right now is finalizing kind of all this SRS parameters that we're looking at. I think the question will be, as we start to analyze this more, is there a relationship between how much of treatment patients receive and how likely they are to develop these complications. Having a low number of complications makes that difficult to analyze in detail, but I think having that data will be helpful. We're also still kind of combing through all the patients we do have to make sure we're not missing any. And then looking at overall survival complication rates and trying to identify any predictors of these adverse events if we're able to. This work's been primarily organized by Dr. Silvergeld, and then the help I've had on the project has been mostly with one of our excellent medical students, Patrick, and then the rest of the radiation oncology team and Gamma Knife team has been immensely helpful in pioneering this project and this work. Happy to take any questions.
All right. Very nicely done, Nick. Oh, I see Dr. Rampey has his hand up. Go
Sorry,
ahead.
I seem to have questions for everybody. So I guess I'm trying to understand, Nick. So obviously there's size criteria for who is a candidate for therapy. And are you trying to define prognostic factors the same way that Meredith is trying to define prognostic factors for, how safely you can discharge a patient for, beyond size, which patients are likely to suffer complications? And if that is your hypothesis, do you have some specifics like is it pathology? Is it overall tumor volume within the posterior fossa? Is it proximity to these, the aqueduct and other vital structures that you mentioned?
Yeah, I think that's exactly it. Trying to define those parameters. I think our hypothesis would be that, one of the measurements we are taking is that how close they are to the cerebral aqueduct size, and then have they had a prior resection. One of the papers, the paper from 2017, looks specifically at the difference between if they were more at risk if they had resection previously. And I think the fact that, one of the three of our complications that I think can be attributed to this did have that prior resection favors that as being a possible predicting factor. I think given how few complications we're actually identifying, I think more what we're actually going to end up kind of seeing with this is just that this is overall safe, and that it'll be hard to actually define any good predictors for true complications, just because we won't have the power to state that. But that would be the goal if we did see a lot and had a lot of that data.
I mean, it's probably end up being safe because you have already good selection criteria worked into your patient selection.
Yeah, that's a good point.
Yeah, I was going to say selection upstream, all these biases, unfortunately, I think, do have contribution. And, for the complications you did note, Nick, I mean, there's just kind of, what would be expected by chance, if you will. I mean, these are pretty darn sick people to begin with. It clears a safe procedure. I think the quick question I had for you was just, how would you take what you've learned to, inform guidelines, for other institutions about these types of patients?
It's a great question that I'll have to think about in more detail.
Okay, no pressure, no pressure to put you on the
No.
spot, but just, because it does seem like it's a pretty solid, stable approach, right? And not every site does this in the individuals the types of patients that you guys are doing, right? And so just kind of thinking about how to inform that more broadly. Okay, well, thank you so much. Excellent presentation. And with time ticking away, we'll move on to our next speaker, Dr. Zack Abecassis. Oh, that's so funny, Zack. Bless your heart. Got the suit on the top. When he showed up, he's got the scrubs on the bottom. So the presenter on the top, the hardworking neurosurgeon resident on the bottom. He's going to talk to us today about some work he's been doing for some time now that he's had some funding on. Looking at traumatic brain injury due to e-scooter accidents, which, oh my gosh, not barely a day goes by that another one doesn't show up in the ED. So some important work, but this time more of the long-term outcome side, patient experience, and some of the lessons learned from their work in this realm. So I'll turn it over to Zack for his presentation. It looks great. You're in the right mode. Take it away, Dr. Abecassis.
Hi, good morning. Can everyone hear me?
Yep, coming in clear.
Okay, sounds good. So I'm Zach, I'm one of the residents, and I'm going to be talking about a project that I actually started looking at when I was in R2, when the e-scooters first came out, when we noticed that there was a pretty big increase in the prevalence of them in a young population that we would often discharge from the ED. And I always wondered kind of what happened to these patients and what their recovery looked like. Just before I get started, see if this works. A lot of this work was made possible due to Richard and Donna Adler generously donating to the cause and giving us the ability to build an infrastructure to complete this research. So background, I don't need to tell this group that e-scooters are prevalent in Seattle. They're prevalent around the country, and it's no secret that they cause injury. And there's been, numerous epidemiologic studies now at major cities showing, a giant increase. And there's a lot that we already know about these patients. We know that they get head injuries. We know that they don't wear helmets. But what I was more interested to try and understand was what was the effect of these injuries and how were these patients recovering? Because, like I said, as a junior resident, you get a consult for a small traumatic subarachnoid hemorrhage. Often our answer would be to, get a repeat scan, discharge them from the ED, and have them either follow up with their PCP. If it was extensive, maybe follow up with us. So what we did is we went through basically from the inception of the e-scooters in Seattle to the end of 2024, and we essentially filtered through all emergency medicine visits that had any sort of scooter. Then we filtered those down to find the e-scooters, and then honed in on patients that had head CTs indicating concern for head strike. And then essentially went through and diagnosed them with TBI based on, the standard TBI symptoms, retrograde amnesia, altered mental status, loss of consciousness. And then, in consolidation with this, we used the trauma registry to obtain cost data. And then we, devised a standardized telephone survey that was based on prior studies that had looked at TBI. And then included a qualitative component to go through and better understand the natural history of this injury. So it started out with about 2,700 ED encounters, including scooters. We went through and filtered that down to about 305 patients that had TBI symptoms. Of those 305, 187 of them had consults with us. And then we also had what we thought would be a control group of patients that basically had concussion-like symptoms but had negative CTs. And this is the breakout. CT positive indicates somebody that had intracranial pathology, and then CT negative, as I mentioned, would be patients that just had gotten a CT due to concern. And a lot of this isn't surprising, and I think has already really been published. Is this idea that it's usually young people, it's usually at night, they usually have alcohol on board. This is a breakout kind of our center's experience, and you can see about 17 of those patients needed some sort of neurosurgical intervention. A lot of these patients went to the ICU. We had 4 deaths. And then, from the cost data, we were able to see what was billed to insurance, and be able to kind of obtain, average cost for these patients as well. Then we did surveys, and we called all of the CT positive patients, and then we selected essentially randomly 20 patients from the CT negative cohort as a control, just to understand what types of symptoms patients were having based on having a positive CT. And it was pretty shocking. I think that you can see here, these are kind of the standard categories of symptoms that patients have with TBI, and you can see that these patients, despite if it was a benign head CT that just had a little traumatic subarachnoid hemorrhage, to obviously patients that were admitted to the ICU and had neurosurgical interventions, that there was a pretty extensive duration of symptoms from having a TBI. And then, I think one of the nice things about this project was we actually were able to get them, after a decent amount of time after their injury, but not too long. So it was about, a year and a half. And you can see that, there was a clear difference between, patients that had positive CTs and patients that had, that were CT negative. And it, didn't just expand to symptoms. A lot of these patients missed, months of work. 1 in 5 patients from our CT positive group had to, get a new job or lost their job. There's a pretty significant utilization of healthcare with, rehab and even mental health counseling. Interestingly enough, only 75% of the patients that came into the ED with positive head CT, so they would wear a helmet in the future, compared to, about 50% of the patients that we had surveyed from that had just kind of hit their head and gotten a slight concussion. Another thing that we noticed, which has actually changed our practice a little bit, is that a lot of these patients, we weren't following up with them, and they weren't getting really any follow-up outside of their primary care doctor. And so that kind of was a little bit of a wake-up call. I feel like, at least for myself, to think about, trying to assure, especially for young patients, that they had appropriate follow-up with our either our rehab docs or with a neurologist. And then, part of the survey, we kind of gave people the opportunity to kind of tell us about their experience and give us quotes on things that affected them. And then we used a thematic analysis to break it out and kind of see the different categories that they covered. And these were kind of the main categories that people, talked about when you kind of gave them a freehand ability to describe their experience. And I think one of the more notable things was, family and caregiver burden. A lot of these patients, especially that had, positive CTs needed, either a parent or their loved one to support them. And then, cognitive, I think not super surprising, is that, people had, brain fog and issues for a significant duration. And these are just some of the quotes that we got from the surveys, just examples of things that patients had highlighted during their surveys with us. I think that hopefully this could help put a little bit more regulation around e-scooters. I think that, the concept of them is excellent, and they provide an alternate transportation modality. But, having some sort of understanding and awareness that, this is putting a young population at risk, and not just for healthcare costs, but, out when they leave the hospital as well. So hopefully this will help us kind of get a better understanding as a city and have some impact on regulatory affairs for e-scooters moving forward. This work was definitely a large effort. Obviously, Dr. Ellenbogen and Dr. Bono, Dr. Walster were all very, very crucial in getting all the resources and guidance to put this study together. And then I just want to give a big highlight to Jack Sedgwick, who's actually going to be taking a year off with our department and coming up in May. But he made, I think, at least 400 phone calls to these patients. And was able to get a really good, almost a 40% survey response rate, which, as anyone who's done surveys knows, is quite excellent. So, and then obviously Richard Adler and his wife for their generous donation to make this work possible.
All right, excellent. Thank you, Zach, for that. I will put a plug and then turn it over to Dr. Ravenpay. I'd be very curious to know the extent of polytrauma in all of those patients, because outcomes don't occur in isolation to the brain, right?
Yeah.
And so we always kind of have to think about that. And my last comment, just to kind of think about, is, we've done very large studies that show rather consistently that CT negative group, about a third of those would have had brain injury lesions identified if they'd been scanned with MRI.
Yeah.
So we kind of think about negative as, a little bit of catched air quotes. It's the best you've got, for the technology in an acute, environment. But it probably doesn't tell you the whole story, and none of the imaging potentially does, just given the limitations in resolution. But it's good work.
We have a very cool figure in our supplemental figures that does break it out by polytrauma. So we have all of that. And it's mostly a lot of it was like maxillofacial injuries. That was probably the most common thing. Some orthopedic injuries, but and then, I agree. I think that even if you look at the data for the CT negative group, they did have symptoms for a reasonable amount of time. They were definitely concussed. A lot more heterogeneity. As you know, we have a pretty low threshold to get a CT on patients here at UW. So I think that it's definitely a much more heterogeneous population. But I agree with you. There are definitely patients that had CT negatives that were, very affected by this injury that when we surveyed them. So.
Yeah. And we're going on to try to understand how to reduce repeat head CT and the CT burden, really. Like, are there people that you can skip? And maybe someday we will be able to. Dr. Ravenpay, I see the hand up. Let me turn it over to you for a question.
Just a quick question. I've heard Zach give this talk a few times, but it never occurred to me to ask. In your follow-up questions, did you ever specifically ask if these patients stopped using the scooters?
Yeah, we did. It's actually we have it as one of our data points, but yeah, most of them ended up not using e-scooters again. But we there's I think it was it's actually I think it's right here actually. Yeah, would not ride an e-scooter again. So about 70% of the patients that had CT positives would not use them again. So
Thanks.
yes.
All right. Well, great work, Zach. With the interest of time, we'll move on to our next speaker. Our next speaker is Adriel Barros Anderson, and he'll be speaking on the genomic analysis of mosaic variants and epigenetic features in drug-resistant epilepsy using tissue from stereotactic EEG electrodes. So going back to some excellent work that he's being mentored by Dr. Goldstein and others. So Adriel, take it away from Seattle Children's. And now y'all are busy up there this morning. Slides look great. You're good to go.
Is everyone able to hear me?
Yep, coming through clear.
Thank you very much for the introduction. Excited to talk about this project that I've been working on and preparing for my research here with Dr. Goldstein as my primary mentor, looking at trying to do genomic analysis in patients with drug-resistant focal epilepsy by using the tissue that is adherent to stereo EEG electrodes that we place all the time. To give some preliminary background, we'll go over the concept medically refractory epilepsy, talk about our SEEG workflow, and then this idea that Dr. Goldstein developed with some collaborators here at Seattle Children's on obtaining genetic information from tissue adherent to those electrodes. We'll go over the study design. I'll talk about some preliminary results, advantages to the study approach, and then some conclusions and limitations. Medically refractory epilepsy, as you all know, is epilepsy that is characterized by being unresponsive to typical medication management for seizures. Typically, it's defined as completion of trials with 2 or more AEDs. The patients still continue to have a significant seizure burden through 20 to 40% of adult patients develop MRE, and that's from a population of around 20 to 40% in childhood. Drug-resistant focal epilepsy specifically is a version of refractory epilepsy that is focal in that there is specific seizure focus or foci associated with seizures. And it's been shown that it can be cured or treated with resection of epileptogenic tissue, as well as targeted stimulation. But only, we see that still about 33% of patients continue to have very severe seizure frequency despite these surgical interventions. And so the field is still looking for an improved understanding of molecular characteristics that define epileptogenesis and understand what it is we're dealing with at a molecular level. And so that leaves a big need for understanding the basis of genetics, which is with the basis of molecular biology, which is genetics. This is an area of epilepsy that has been studied in animal models and in humans. Most of the literature of genetics and epilepsy in humans comes from tissue that was processed from very large resections, whether it's hemispherectomies in children, large lesionectomies, as well as anterior temporal lobectomies in adults. There are genes that have been associated with epilepsy, as well as certain genetic drivers that come back up and have been reproduced in translational animal models. And you can see some of these drivers here are some of the genes that keep coming up in focal epilepsy. Another more recent thought about genetic drivers for epilepsy is this concept of somatic mosaicism, which is broadly, the definition is the presence of 2 or more populations of cells with different genotypes that exist in one individual. And the thought is that somatic mosaicism may explain why focal epilepsy, specifically certain parts of the brain having tissue that behave differently from other parts of the brain in the same person, can lead to epilepsy or lead to seizure development. Additionally, epigenetic work, which is more novel, has been associated and implicated in the possibility of epilepsy, because if it's not different genes that patients have, it may be differential expression that leads to the development of focal epilepsy. And so this preliminary work, which has been really driven a lot in the human model by large resections, is still limited by how much we can get samples. And that brings us to the stereo EEG workflow that we know well as residents here, as well as both at Seattle Children's and at Harborview. We place depth electrodes where we have patients in the epilepsy monitoring unit. A lot of data is collected after the electrodes are in place. Behavioral data, electrophysiologic data. We're looking typically for seizures. After we do these procedures and get the data we need to develop an operative plan or a medical treatment plan, those electrodes are typically discarded. We just toss them after removing them. So we have this setup where we have a wealth of electrophysiologic and behavioral data that's collected, but tissue data is quite limited. And that brings us to the proposed study design that Dr. Goldstein developed with collaborators here at Seattle Children's, which is to do the SEG placement, remove them, but instead of just throwing away those leads, actually collect tissue adherent to those SEEG leads, and use that tissue for genomic and transcriptomic analysis. The reason for looking at it for genetic evaluation is because not a lot of tissue is adherent to these leads, as you know, if you've ever removed them. But there is just enough, it turns out, to get information about the genomic features associated with the tissue that is in contact with the leads. And so the goal of this study design is to obtain this genomic data and then bin it with the data we get from the electrophysiologic and EMU data that for each electrode. And so you have an electrode in a specific anatomic location, and then that electrode and the electrophysiologic data we get from it that characterizes it, often by our neurology epileptologist, as a seizure onset zone, a seizure propagation zone, or an uninvolved zone, an area of the brain that doesn't seem to be involved in the seizures recorded, and then use those individual electrodes to get tissue that then we can co-localize with this binned data to get more information. So our hypothesis that we are working from is that the idea is that a seizure onset zone harbors distinct somatic mosaic variants, RNA expression patterns, and DNA methylation patterns that can be detected by analyzing tissue from these SEEG contacts. Our preliminary data that we've been working on and really has been pioneered by Dr. McCarthy in his lab, a genetics lab at Seattle Children's, is using an RNA and DNA extraction method that has been used at other institutions for this same type of protocol to obtain enough information, specifically enough material, both RNA and DNA, that can then be used for sequencing. Our preliminary results showed that RNA was much more there's a significantly higher yield compared to DNA. However, more recently, we've improved our yield with DNA as well. The proposed design, which is largely exploratory and descriptive at this point, is, one, we're seeing much more RNA than DNA, but eventually we're getting to a place where we're seeing a similar rate of recovery that is then available for analysis of these tissue. This is an example of some of the long-read data output that we can get from long-read DNA sequencing. And I use it really to illustrate the rich data set that we can collect from a single electrode in each patient. You can see here, based on this read, we're not only getting information that at the granular level gives us information about specific genes, but it also has some of the epigenetic markers that we can look for specifically that show genes that are being turned on or off. Each data set for each electrode exists for each patient. And then the SEEG electrode data, both the electrophysiologic data that we get from the leads themselves, that's determined by our, these bins that our epilepsy team develops for patients, can then be combined with this genetic and epigenetic information to yield quite a bit of data for each electrode and then expanding for each patient. Some of our preliminary results are showing that there is feasibility to this method, which is still quite novel. We are obtaining neural tissue and it's sufficient data for DNA and RNA sequencing. We did some preliminary analysis that shows that we are getting gene expression that represents that what we're collecting is what we intend to. We're getting neuronal tissue, we're getting glial tissue and tissue from the brain, which is key. And then we are getting enough tissue to do some of the sequencing that we're interested in. And so the advantage to this study approach is, first, we're no longer limited by just resected tissue. And then we can combine this tissue data with the depth electrophysiologic data with the hope in humans of seeing if we can come up with a link and an understanding of how genetic material is linked to electrophysiologic findings, and in the hopes of coming up with a molecular link for epilepsy, what we're seeing in the behavior. There are a lot of limitations to this study. And first, it is largely descriptive. It is limited by sample size. The hope is that this deep within patient data set wealth of data that we collect as a result of this study will be able to give us some information to guide hypothesis generation going forward. There's a limitation of where the tissue we obtain is coming from, which we are beginning to answer by doing some of our analyses of the specific cell types we see along the electrode. But even still, as you know, the electrodes are passed through the brain. And so the precision of the exact place in the tract where we are getting cells from still remains a question. That said, the hope is that this preliminary study and this work helps us move towards developing a genomic and epigenomic understanding of focal epilepsy that can guide improved precision medicine and surgery for drug-resistant epilepsy. I'd like to acknowledge all of my mentors that have helped with the development of this project, and I look forward to getting to work on it in the coming research year. Thank you for your time.
All right, excellent presentation, Adriel. Open it up for any quick questions. I am not seeing any. I just wanted to ask you a quick one, and I know, when you were doing your grant submissions too, I was like thinking more and more about this. Do you find that there's anything specific about the patients that you pull those out of that you're noticing, trends or themes and people that, kids, adolescents that work better in, is there anything about the profile of those patients themselves that seems to kind of inform likelihood or lack thereof of some of the sampling?
The likelihood of getting the samples
And getting a solid, getting that profile, or is it that you're getting that consistently regardless at this point?
Yeah, there are a number of factors. It actually has less to do with the patient profile per se. We get more information the more electrodes we place.
Just, okay. Yeah.
And then, this project, the goal of it, this focus is on focal epilepsy, but we're doing this for patients with non-focal epilepsy, patients with Lennox-Gastaut, who have a variety of loci for seizures or may not have a specific seizure focus.
Diffuse, yeah.
But I think that the question on how useful it is still remains to be seen in terms of doing our analysis of the information we have to see.
Yeah, that's one thing is multiple steps forward, are there applications to more than just that very focused group? But yeah, you're off to a great start. Okay, well, in the interest of time, we'll switch to our very last speaker. We're going to go to Dr. Evgenia Chertova. She's going to tell us about analysis patterns and variability in intraoperative local antibiotic administration in spinal surgery patients in our specific state. So I will turn it over to Dr. Chertova for her presentation. Oh, and slides look great. You should be good to go.
Perfect. Thank you, Dr. McDonald. Can you hear me?
Yep, coming in clear.
Amazing. So I would like to present a study analyzing patterns and variability of intraoperative local antibiotic administration in spine patients in Washington State, which I was completing under the guidance of Dr. Khan. And I have no disclosures. So there is evidence that standardization of perioperative management for patients undergoing spine surgery can significantly improve outcomes, and numerous initiatives thus have been created to standardize care. Spinal surgical site infections are a significant and common complication in these patients, negatively affecting patient outcomes. Majority of infections after spine surgery occur within first 3 months and have multiple risk factors contributing to their occurrence. There is class 1 level A evidence and guidelines for administration of IV antibiotics within 60 minutes before surgical incision, which is followed by appropriate redosing during surgery. However, there is still some controversy in literature and no solid guidelines regarding whether the use of antibiotics at the site of spinal surgery, such as powders or antibiotic beads, has an effect. In theory, intraoperative local application directly kills residual bacteria, reduces the risk of early colonization, and interferes with bacterial adherence to the implant surfaces. However, some studies show that excessive use of antibiotics can result in the escalation of bacterial resistance. The goal of our study was to analyze the patterns of intraoperative local antibiotic administration in the state of Washington and correlate variations with clinical outcomes. In particular, we aim to assess variations of local antibiotic use based on year of intervention, patient demographics, and medical comorbidities, employment insurance status, type of surgical procedure, and hospital stay. The outcomes of interest include occurrence of surgical site infections or SSIs during the index admission and after the discharge, as well as the need of non-operative and surgical interventions for infection management, length of hospital stay, 30-day readmissions, and survival. For this study, we utilized SpineQueb database, which is a Washington state-based physician-led clinical quality improvement collaborative, which acts as a database and a benchmarking program. SpineQueb chart abstraction captures clinical information on elective cervical and lumbar procedures. There are currently 17 hospitals participating in this initiative, representing about 70% of spine surgery done in Washington state. For this study, we extracted 70,000 procedures performed between 2011 and 2025 in adult patients and included 549 variables capturing patient demographics, operative and hospitalization details, and clinical outcomes. Overall, it's a massive data set and it's a project in progress. Thus far, after cleaning the data, excluding entries with insufficiently reported data, we performed initial univariate analysis. With large sample sizes, even trivial differences can appear statistically significant, and sample size varies across variables. In this data set due to missing data, making p-values less valuable here. So we utilized standardized mean difference, which is less influenced by sample size, to quantify the magnitude of difference between the two groups. So in our data set, mean patient age was 60 years old, about 70% of cases were lumbar, 30% cervical, 75 open, 25 MIS. Intraop local antibiotics were used in about 60% of reported cases. The graph here represents the rate or the proportion of patients who received intraop local antibiotics by admission year, interestingly demonstrating temporary drop in use between 2020 and 2022 COVID years. When comparing the groups of patients who received or did not receive intraoperative local antibiotics, we found no difference in mean age, gender, medical conditions, BMI, race, or work status. Interestingly, there was a small difference based on insurance type. High proportions of patients who had a private payer received local antibiotics. Overall, no significant difference in the use of intraoperative local antibiotics was seen when we looked at broad categories, cervical versus lumbar, open versus MINs, instrumented versus not. However, when we looked at the more granular data, we saw that high proportion of patients undergoing posterior cervical procedures, posterior cervical instrumented cases, anterior instrumentation such as cages, posterior lumbar screws and rods and interbody fusions and plates received local antibiotics intraoperatively, but the difference again was small. We then looked into the incidence of SSIs during index admission, and from initial analysis, proportion of patients who developed deep infections and needed antibiotic from treatments of SSIs was higher in a group that did not receive local antibiotics with moderate size effect. But on the other hand, in this data set, proportion of patients who developed superficial wound infections and needed implant revision or had a higher post-op hospital mortality was surprisingly high in the group of patients who received in-wound antibiotics. I would take this data with a grain of salt, given that confidence intervals were wide and effect size was small, and mean LOS was only 2 days. But then we turned our attention to SSIs in post-discharge period. Proportion of 30-day readmissions seemed to be higher in the patients who did not receive intraop wound antibiotics with mild difference effects. Proportion of patients developing superficial SSIs and needing operative wound intervention, abscess drainage, operative brain placement or even having to undergo a negative exploration was also higher in the group who did not receive local wound antibiotics with mild to moderate defenses. So conclusions, the spine co-op data set, which spanned 14 years and included 70,000 cervical and lumbar cases, we demonstrated that intraop local antibiotics were used in about 60% of reported cases in the state of Washington, with some propensity to use this intraop wound antibiotics in instrumented posterior cervical cases, instrumented lumbar cases, interbody fusions. Proportion of post-discharge superficial SSIs, as well as the need for their operative management and 30-day readmission, seems to be higher. In the group of patients that did not receive intra-wound local antibiotics, but again, this is a project in early stages, and the key outcome, which is the incidence of surgical site infections, is multifactorial and likely represents a composite outcome measure, which may, of course, not be fully explained by intraoperative local antibiotic use and has multiple confounders. So carefully designed multivariate regression will need to be performed, and it's our next step. Other study limitations stems from the nature of the utilized data set. Multi-center quality improvement database offers a large sample size and allows for enhancement of generalizability, but the key issues include data heterogeneity, variability in staff expertise collecting data, potential inconsistencies in data reporting and collection, and lack of ability to perform additional chart search for necessary details. Now, the challenges eventually, of course, translating findings into actionable quality initiative. And as I mentioned, we still have a lot of work and analysis to complete within this project, but we also have future projects planned for our spine co-op data set in regards to post-op DVT prophylaxis and pain management, including postoperative pain management and incidence of discharge on opioids and long-term opioid use. We also seek to establish patterns of utilizations of intraoperative neuromonitoring and correlation with surgical outcomes. And here I would like to say thank Dr. Khan, who is a principal investigator for this project, and our statistician, Vincent Jean, who has been very helpful with working with this massive data set. And I'm happy to take any questions.
All right. Thank you, Evgenia, so much. I see Dr. Robin has his hand up, so we'll go to him.
Evgenia, you may have included that in your slides, but I couldn't see them because of small print. Did you specify what kind of antibiotics they were used? And also, is there any thought to include, presence or absence of antibiotics in irrigation also as part of this question?
This is a great question, and I think that would be a great thing to look at. However, this data set doesn't have this granular of a data, and this is a limitation of this data set.
Although kind of building upon that, I actually wanted to ask you, Evgenia, because you have the state data, if you looked, it should be reported out by hospital. Did you notice any specific trends in, kind of region or by hospital or level of center that sometimes would inform some of this kind of, peripheral support and decision making just purely because of the institution of which these patients were presenting to?
That's also a great question, because I know that some centers are have more propensity to use them than others. Right now, we do not have this data extracted, and something that we can definitely look into is whether it's possible to obtain this geographical data.
Excellent. Okay. Any other questions out there in the stratosphere? I think you're officially off the hot seat. Thank you so much for your presentation. That also concludes our program for today. I first and foremost actually want to thank two individuals, Megan and Garrett, because without them, this would not happen. I am very grateful and thankful for the residents for coming and sharing their talents